Welcome to the module on steroid-induced hyperglycemia and managing glucose levels with those with pre-existing diabetes using steroids. I want to acknowledge with gratitude that this presentation was created on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and want to thank them for their stewardship of these lands over time immemorial. So the objectives of this is that we will define steroid-induced hyperglycemia and strategies to manage SIH and those with pre-existing diabetes, because they're two different things. And then we'll review a case study. So steroid-induced hyperglycemia means they didn't have diabetes before. They may have had a family history or gestational diabetes, but they don't have diabetes when they start the steroid. And that when they're taking the steroid, it makes their glucose levels go up. So once the steroids are discontinued, the glucose may return to normal, or it may kick them over into type 2 diabetes. So that's where they would not have SIH anymore. So it's common knowledge that glucocorticoids can cause hyperglycemia because of three things that happen when you take a steroid. It increases the amount of glucose production from the liver, and it prevents glucose from being uptaken in the muscles and adipose tissue, which is where it's supposed to go, and it increases insulin resistance. So different steroids have different effects due to their potency, the time that it was given, or the route of administration, knowing that IV will impact it more than PO. And those with pre-existing diabetes will likely experience higher glucose levels when taking glucocorticoids because they already have an issue with their pancreas. So what's the problem with steroid use? Well, we know that steroids increase their appetite, and especially comfort foods that contain carbohydrates. And so that doesn't help things when we're adding glucose to the system. It creates insulin resistance that doesn't allow the insulin to work properly in the body. So it puts extra layers between the insulin grabbing the glucose and trying to get it across those membranes and into the cell. And the resulting hyperglycemia can increase swelling, cause nausea and vomiting, dehydration, polyuria, polydipsia, fatigue, and an overall feeling of unwell. So not a great thing, but steroids actually have some good purpose and needed purpose, especially renal transplantation, in respiratory issues. They are definitely needed. So we just have to deal with the resulting increased glucose until the original problem is gone or controlled. So this is a time action profile of dexamethasone versus prednisone. So prednisone's on the left here, and we can tell that when we give the prednisone, within about 4 to 6 hours is when the most havoc is wreaked on the glucose levels. So if we want to test somebody's fasting blood sugar who's taking prednisone once a day, it's going to show normal levels, because look at how quickly it causes the insulin resistance and all of the other hepatic glucose release and the lack of uptake in the muscles and adipose tissue. It's causing all of that after the 4 to 6 hour mark, and it's wearing off at about the 18-hour mark. So if someone only takes prednisone once a day, they will have normal glucose levels by the morning. If they're taking it twice a day, different ballgame. And you can see that dexamethasone acts a lot, does a lot more. It's actually more potent and can cause the sugars to go even higher. But their peak is actually earlier than prednisone. So often people are on dexamethasone sometimes 2, 3, 4 times a day. And at that point, you are dealing with all of those side effects and negative effects on glucose control with dexamethasone 24 hours a day. Reminder as to what normal pancreatic function looks like. So this is a picture of what the insulin levels would do in response to a climbing glucose level. If this person's eating 3 meals a day, you're going to see 3 spikes in the glucose and a resulting 3 spikes in the insulin level. That's how it should work in order to keep our glucose levels between about 4 and 8, 4 and 10. And you can notice here as well that the insulin levels never go down to 0 because we always need glucose in our system in order to feed the brain, the heart, the kidneys, vital organs, right? So this is what we're trying to mimic if someone has steroid-induced hyperglycemia or on steroids with existing diabetes. We want to think about when are you eating in addition to when is that prednisone or dexamethasone peaking, because they could be different than when the person is eating those spikes in glucose. So our treatment goals, we want to avoid moderate to severe hypoglycemia in all cases, right? That's the first thing we treat, hypoglycemia. We want to avoid excessive hyperglycemia. They may have little spikes, they go to 15 and then they settle right back down again. And I'm not saying it's wonderful for them, but as long as they're not being left in a hyperglycemic state, we sometimes don't have to get as aggressive if they're recovering quickly from it. And that often happens in people who have steroid-induced hyperglycemia, as opposed to type 2 or type 1 diabetes on steroids. So they do have a functioning pancreas. It just is too much, the steroids too much for the body to react with extra beta cell secretion of insulin at the time that the steroid is peaking the most, but then it resolves completely again overnight and into the morning hours. So we want to prevent hyperosmolar hyperglycemic state, or HHS, and diabetic ketoacidosis, or DKA. We want to assess the patient's abilities to self-manage diabetes. So you know that we often titrate the steroid according to their response. If you're in a renal transplant, for example, you could have decreasing or increasing doses depending on the day and how many weeks post-op you are. So they need to be able to react in real time at home. And that can be very challenging for people to get permission to adjust their own insulin, their own diabetes medications. And we want to provide education on signs and symptoms and treatment of both hyperglycemia and hypoglycemia, and especially driving guidelines. Because let's say that the prescriber decreases the steroid dose, but doesn't mention anything about decreasing the insulin that they're taking, and they're new to diabetes, steroid-induced hyperglycemia, they're not going to know what hypoglycemia feels like. And so we need to make sure that they understand what those signs and symptoms are, and that they can either seek treatment or they have the guidelines at home to be able to adjust their medication, insulin or pills, to avoid hypoglycemia and hyperglycemia. So while on glucocorticoids, they could use a sulfonylurea or a non-sulfonylurea like a repaglinide, glucanorm. They may use a glycoside and not the MR. They might use just the plain glycoside in the morning with the prednisone because that will wear off, whereas the glycoside MR lasts for 24 hours. They may need insulin, and that's probably where our, NPH or N comes in, where they could take, if it's once a day dexamethasone or prednisone, they could take the N or NPH in the morning with the dose of steroid, and that could match up very nicely with when the peak of glucose is happening. They also might need, extended long-acting insulins and MDI because they're on multiple steroid doses per day. We have to just react to how their glucoses are presented to us. And we must monitor this closely, which is a real challenge if they're in a, let's say they're in an oncology program where the oncologist is making the adjustments to their steroid, or a renal program, or whatever it might be, respiratory program, and they don't have someone who really knows how to adjust the insulin well, or the AHAs. It can be a challenge because they can get lost where they don't have follow-up. So it's really imperative they know where to go to ask their questions. and knowing that if the steroids are being reduced, they need to reduce their treatment that was combating the high glucose along with that reduction in steroid. So some of the suggestions, people with existing type 1 diabetes might have more labile glucose levels, and that is because their liver is not producing, storing, or releasing the glycogen appropriately, so it kind of is a mismatch. And they generally should not have their basal insulin held. We don't want to hold that really in any case, even pre-op. We try not to hold their basal insulin because they have no ability to produce their own. Patients with existing type 2 diabetes, they may need to increase the dose of anti-hyperglycemic medications or transition to insulin when the steroids are used, and that's where we would have close follow-up to see if they've kind of kicked themselves over into needing the insulin. And I do have a bit of a threshold in my experience, which was 15 millimoles. So when someone had consistent glucose levels that were over 15, there weren't really good options in the AHA realm and sphere that would control the glucose levels, and we needed to have some degree of insulin on board. When they were maintained less than 15, we often could control it with AHAs. So patients with steroid-induced hyperglycemia are more at risk for poor management. As I mentioned, they might not be followed by an endocrinologist or a diabetes health center because they're in a respiratory program or they're getting steroids from a prescriber who's not as comfortable with insulin adjustment. And we need to ensure that all patients on steroids are provided education on how to detect a hypoglycemia, how to treat it, and again, those driving guidelines. We want to make sure they know that they should have a glucose generally over 5 to drive, that they should bring glucose source with them. They know how to test their glucose levels, and they know how to treat it and wait at least the 40 to 50 minutes before they resume driving again. So what are the options? Well, metformin decreases insulin resistance. It's a great drug and generally well tolerated and inexpensive if they're paying out of pocket. The sulfonylureas that we would use would be glyburide, which is not a favorite, but definitely is something that can be used once a day in a once-a-day prednisone, dexamethasone in the morning space. Gliclazide plain, or if they require 24-hour coverage, you could use the gliclazide MR, and repaglinide or glucanorm, which isn't used often, and it's not covered in it very well, but it's pretty inexpensive, and it can be used as almost an oral form of a rapid-acting insulin because it's in and out in about 4 to 6 hours. So it can get in, kick that pancreas into gear if they have enough insulin in their pancreas, combat the high glucose levels, and then it wears off, which is perfect for someone who already has a functioning pancreas, but it's just under stress because of the steroid. And I mentioned insulin NPH given at the same time as a once daily dose of prednisone or dex, and a rapid or fast-acting insulin if needed, because sometimes they need that extra help. A basal bolus regimen, long-acting and rapid or fast-acting insulin if taking BID or QID doses of glucocorticoid is also helpful. But it's individualized. It could be a mix and match of any of these things, and it depends on if they have renal issues. If they have a renal transplant, you can use metformin again, but if they still have some underlying renal impairment, then of course we're cautious with metformin. If they have any allergies, if they have an aversion to wanting to take insulin, we're always dealing with that as well. So this is Michael. Michael's 60 years old. He's newly diagnosed with a right frontal glioblastoma tumor. He's got no history of diabetes, but his parents both had type 2 diabetes. So he initially presented with seizures, treated with dexamethasone and surgery, and now he's on prednisone, 4 milligrams in the morning at 8 o'clock. There's no A1C on file, and his hemoglobin looks good, his creatinine looks good. So now he's being treated with radiation and temolizumab, and in the community he's having his glucose levels checked at 7:30 in the morning. all the fasting sugars are between 7.3 and 8. So they're saying, little high, but not too bad. And his symptoms are fatigue, polyuria, and polydipsia, which, if you think back to what the complications of hyperglycemia and the symptoms are, that matches perfectly. So what would you advise to do next? So I'm going to give you a minute to take a look here and make your decision. So if he's going to go to test his glucose, how often and what time of day would you recommend that he test his glucose? Would you start with an anti-hyperglycemic agent or with insulin? And 3, if so, what would you choose and how much would you choose? So you can pause this and take a moment to think about what you would do in this clinical scenario. So here's Michael. We finally get him testing 4 times a day, and this is what we're seeing. His glucose levels are peaking to around the 15 mark at lunch, which is pretty typical of prednisone, and he's starting to back off, and the sugars are starting to resolve in the HS and in the breakfast times. So what they did was they started him on metformin because his glucose levels are relatively 15 and under. It's probably safe to start with the AHAs first, and let's start with one that combats insulin resistance. So remember, his symptoms include fatigue and polyuria, and the effect of the dexamethasone on blood sugar is more prominent in the postprandial. So remember, it's about 6 hours, 4 to 6 hours. And so this really demonstrates the case of not relying on fasting glucose levels alone. So we had him test 4 times a day just to make sure that we could capture everything. And if he's really struggling with 4 times a day, have him test at least 2 hours after lunch. That would be the key. If he can do twice a day, then you have him test after lunch and at bedtime, and then perhaps the next day you have him test fasting and supper. And that way you're getting a picture of 4 times a day over the course of a week or so, and you're seeing the full picture where he isn't having to test so often. And so we get him on the metformin, 500 milligrams, and he comes back here. Look, his fasting glucose levels are now within target, but things are going a little bit haywire the rest of the day. So do you think that the current therapy is adequate with just the metformin? It seems to be working for the overnight time. It's brought his fasting levels down. It's brought his lunch down a little bit, but it's really not doing well for the rest of the day. So here's some options for you to consider. What would your next step be? Increase the metformin to 1,000 milligrams POBID. Increase it to 1,000 milligrams and start glyburide, 5 milligrams in the morning. Increase the metformin to 1,000 milligrams BID and start insulin NPH, 5 units at breakfast, or there's no change required. So have a moment to think about that, and you can put this on pause to think about it. So here would be something that we would start next with him, is that although his sugars have gone over 15, let's bump up that metformin, because we know it did a pretty good job for him in decreasing the insulin resistance. He's steroid-induced hyperglycemia. He's also dealing with glioblastoma. So that's not a pretty cancer, and prognosis are never really great. So we don't want to make the diabetes the prominent problem in his life. We want to make it as gentle as possible, and if possibly he can be managed on glyburide in the morning, and we can increase that dose of glyburide. We could start gliclazide as well if that doesn't work. So maybe the next step would be just another gentle step up and see where we're at. You could also, and the reason I put both of these on here is that depending on his acceptance for things, you could start him on an NPH at breakfast if he's accepting of that. But there really isn't a wrong answer here in terms of which one you would choose. You just except for no change required. He does need some intervention. So I also want you to take a look at the special populations. Take a realistic look at the patient. So palliative patients, pancreatic cancer, psychiatric patients, cognitive impairment, financial and social situations, nephrology patients, doses, the dose of glucocorticoids and changes in dose, they all need to be considered as to what someone can manage in their life that doesn't make their diabetes the prominent, prevalent problem that they're dealing with. And that's something hard for people who work in diabetes to sometimes see, is that their diabetes is not their primary focus, and that possibly their other issue that brought them into this space actually is the prominent thing. So we make it as gentle as possible for them. So set your patient for success, up for success by ensuring follow-up with a diabetes health center or family doctor who's comfortable in diabetes management. Provide the prescriptions for the supplies. They shouldn't have to call back and say, I went to the pharmacy and I don't have any test strips, or I went to the pharmacy and there's no needle tips ordered on here. Educate the patient about the effects of steroid use on blood glucose. Hyperglycemia can cause increased blood sugar, thirst, voiding, so that they know what those signs are and don't attribute it to something else in their health history. And if the patient's taking an anti-hyperglycemic agent, educate that as the steroid is reduced, they may need to reduce that drug and monitor that closely, or at least alert their healthcare team that their steroid dose has been reduced. And provide some education materials, low blood sugar, steroid-induced hyperglycemia, hypoglycemia, and driving guidelines, so that they know what they're looking for. There's nothing worse than having these symptoms and not knowing what to do with them. So the key messages are that glucocorticoid can cause steroid-induced hyperglycemia in people who have prediabetes or in the at-risk stage. It can also very likely cause an increase to blood glucose in those with type 1 or type 2 diabetes existing. And those glucose levels need to be monitored closely when you're using glucocorticoids until it's stabilized out. If they're on long-term steroids, then it could stabilize out. But when they're titrating the dose, it's really important to keep a close eye. Metformin, sulfonylureas, and insulin are excellent choices to manage steroid-induced hyperglycemia because they're a little gentler. And if the person is going to resolve after the steroids are removed, we don't want to leave them with existing hypoglycemia because we've put them on something so aggressive. And patients should receive education in what the signs and symptoms are of hyper and hypoglycemia, and alert the healthcare provider to any of their concerns, as well as reviewing hypoglycemia and driving guidelines. So thank you for your attention today.